Good morning. Thank you to Dr. Phillips Reed and Sisters by Choice for the opportunity to participate in today's symposium presenting on breast cancer disparities. First, I'd like to recognize that when speaking about disparities, that includes a diverse population of women. We often think about race, socioeconomics, and insurance status, but remember that also includes others, such as those living in rural areas, disabled women, LGBTQ plus population, women with low literacy, women with mental health conditions, and a host of other social determinants of health that we must consider. Here we see the trends in breast cancer incidence by race and ethnicity. Of note that in general, there has been a slight increase in breast cancer among all groups over the past 10 years. Statistics show that the increase has been faster among Black women. The rate of death from breast cancer has been decreasing for some time, but rate of death among Black women is much higher than all other women, and this large difference has persisted for more than 10 years despite all the improvements in treatment. The speed of decline in breast cancer deaths has been slower among Hispanic, American Indian Alaskan Native, and Asian Pacific Islander women. So looking at what impacts breast cancer deaths, we start with thinking about early diagnosis, since we know that early stage disease has a higher survival and less morbidity than late stage disease. It is interesting that the rate of mammography use has been on a slight decline. Looking at mammography use by educational status, we see that those with less than a high school education has had a similar trajectory, but over time, their mammography use has been persistently lower. This could lead to women with low literacy more likely to be diagnosed with later stage disease. These graphs look at metastatic disease. Even though it is recognized that biology has some impact on breast cancer survival, here we see significant differences by race among women diagnosed with metastatic cancer. On the left, we see the incidence and mortality of metastatic disease is higher among Black women. On the right, we see the same difference with higher rates in Black women among all age groups. Now, I'd like to look at some more contextual factors that may impact the disparities we see by looking at social vulnerability. There is more and more evidence that our health status is directly related to the context in which we live. This is a map of redlining neighborhoods in the Cleveland area from the 1940s. These maps were used by banks to indicate the best areas for mortgage loans. The neighborhood outlined in red are areas that were deemed to be too high risk and were in the poorest communities. Therefore, these areas had less economic growth. When you look at these maps and overlay the population of African Americans, you see that these poor areas that were considered too risky for investing are the same areas where larger percentages of African Americans live. Now, looking at areas of highest need for breast cancer services because of the highest mortality rates, you see those areas in the dark blue are in the same locations as the low-level red line areas. Also, you see that the available breast cancer resources, the yellow circles, are spread throughout, with some high-need neighborhoods having very little resources. But this doesn't just relate to breast cancer. It's associated with the bigger picture of healthcare availability and utilization in these poor neighborhoods. This map has infant mortality overlying the redlining map. This shows that infant mortality was highest in the areas that were considered too risky for mortgage development and where most African Americans lived. So the point is that disparities set up from many years ago still linger today in some neighborhoods and impact us in many ways. So, what are some of the general issues? One, there's lack of access to clinical services. Over the years, many hospitals and clinics have closed, often impacting low-income and rural areas first. The never-ending problem of people not being able to afford health care, especially when it comes between paying for rent and food versus paying for a test when they don't feel sick. Then there are competing health issues. Studies have shown that many people seek medical care for other conditions, yet don't get recommended cancer screenings. These are missed opportunities here. There is still mistrust of the healthcare system. With all the historical events, like the Tuskegee study and misuse of blood samples for American Indians for research without their consent, many people still do not trust healthcare systems today. There is always an unconscious bias in the interpretation of what we hear. I think for all of us, we tend to see things from our own perspective and experiences, and not always do we see things as they are. This goes both ways: a provider's communication to a patient and a patient's communication to a provider. And then there's the dreaded fear or fatalistic beliefs. I still hear things like, I don't want to get cut open because cancer will spread when the air hits it. There's also been a situation where women didn't want to get a mammogram on a mobile band because they believed that women got cancer from the band after some women were diagnosed with cancer. We still have a ways to go with making sure people really get the information that they need in a way that they can understand it. Then, with all of this going on, we are now dealing with a major pandemic to cause an even larger disruption to care. One study that modeled the impact of reduced cancer screening for the first 3 months of a widespread shutdown found that there were an estimated 7.3 million less mammograms performed, which could ultimately result in 36,000 delayed diagnoses of breast cancer. So, to address disparities, we need to first go to where people live and work. Healthcare needs to make adjustments to fit with the times, even beyond the current pandemic. Bring services and support to the people. Use community health workers who are trusted members in the community to help people understand the issue and find opportunities to screen. Look at providing more opportunities at work sites to reduce the restraints of work requirements. Provide education and referral through pharmacies. Broaden use of telehealth to reduce the amount of required office visits. Be more purposeful with including cultural competence. This can help reduce bias, develop trust between patients and providers, help patients feel more comfortable and understood, create social acceptances, identify and address linguistic differences, and help respect each other's identity. Expanding care can go a long way. Mobile clinics can take services where opportunities are limited. Extending clinic hours, which has been shown to increase screening rates, when there is competition of time between work and school. All of this, though, will require some revision of policies, like reimbursement to cover use of community health workers, continued relaxation on some of the telehealth requirements, use or expanded use of internet services in rural areas and to those who are low income who may not afford the internet. Also, incentives to offer the extended hours in clinics. This is not an easy. It requires work from all aspects of healthcare. And just like in Cinderella, one glass slipper does not fit all. We have to address equity by providing patients what they need to get the desired outcome. That does not mean providing equality to all. Thank you again for the opportunity.